last topic, and then this is really we talked about sort of immune therapies and the future there, but I know everyone on this panel is excited about the concept of broad molecular profiling, finding other novel targets, the breakthroughs that Alan alluded to earlier. So Johanna, talk a little bit, when should we be doing broad profiling on patients? What utility does it have?
So personally, I do it when they're first diagnosed with metastatic disease, where it's non-curable. And so I try to do what I call one-stop shopping. There are a lot of molecular profiling platforms that allow you to test multiple things at once with one tumor sample. So you can get microsatellite instability, you can get expanded RAS, and you can get HER2 status, because we've also seen some recent data that, again, 5% of colorectal cancer patients with metastatic disease potentially have overexpression of HER2. And we've seen data with both trastuzumab and lapatinib and trastuzumab and pertuzumab showing nice responses and durable responses that we see for these patients. So trying to pick them up, but also trying to collect this data. There's a lot of big movement now to collate data from all of the molecular profiling that we're doing on these patients to try to get more broad strokes about who's going to respond and why, and then also the potential someday for longitudinal molecular profiling. What changes along the way, and is it the cause of these therapies or not, and how do we get a handle on that?
You're a policy guy, Alan. Should insurance cover broad profiling for our patients?
I think they should, but what I think in return, I think there should be a way that they can be assured that these results will not be overinterpreted or misinterpreted. I think, to me, the flaw is not in the analysis, it's in the application of the findings. So you get some of these printouts that say, you know, recommend everolimus or recommend azarubarb, and I think the answer is no. And to me, though, insurers should be covering it. It's hard. I'm hard pressed to see how they can demand that we have proven results and benefits of the testing if they don't cover the testing in the first place, much as they did decades ago with bone marrow transplant for breast cancer. Yeah. I think if we could deliver on making sure that these are not overinterpreted, I think that would be a big difference maker. And I think the other thing we're doing, of course, is we're at academic centers is doing serial analyses to see what the changes are. That's a research tool, of course.
Well, and the more I'm doing this too through our sort of national collaboration, and the more I'm doing this, the more I'm seeing RAS change. I'm seeing, you know, and so should we be re-biopsying patients like they're doing in lung cancer, like they're doing in breast cancer?
Well, I think the concept of free biopsy is certainly interesting. I think, though, and I'm hoping that ultimately the liquid biopsies are going to become the standard in this field and will actually afford us with the opportunity to have a real-time view. You know, colorectal cancer is one of those cancers on the top of shedding circulating DNA into the circulation. So it's actually a good target disease for liquid biopsy and essentially looking at the changes, the molecular and genetic changes in real time through a blood draw, rather than putting a needle in the liver.
We're all hoping that's true, but from what I know that today, I mean, you can do a liquid biopsy on these patients, but I understand their tissue correlates are not, well, I'm not relying on it.
Well, they yes and no. They're reasonable. And actually, there's a poster tomorrow presented at ASCO GI that shows actually very close correlation. You do depict, for example, more EGFR mutations when you correlate to older tissue, but we know from rebiopsying tissue that a number of these actually do change with time under selective pressure from EGFR inhibitor application. So I think the tools need to be refined, and they are being refined, but I do think that there is some level of utility.
So it's not crazy to think about rebiopsy. If you're arguing, and I think I agree with you, Johanna, that, you know, I want one-stop shopping, so if I'm going to do my MSI, RAS, and BRAF, what the heck, let's just do it all right now and know. Yeah. But let's say it's 2 years later, and I got a big liver met I can get a piece of?
Yeah, so I do it in the context of clinical trials, right? So you're doing it as part of research, because that's mostly what you're going to find in those changes that would change your treatment pattern at that point in time. But if you have a reason that result's going to change what you're going to do, whether it be clinical trial or your practice, then I think it's reasonable to do it.